All right, well, that's some great innovation, a lot of great change, and hopefully all of this is working towards a better system from a lot of great people in this room that are trying to work to make it better. And for you, we appreciate that, the work that you're doing. We're going to shift gears a little bit here, still within the mental health realm, and we're going to have Jan Dobbs, who is with Frontier Behavioral Health in Spokane, and she is going to talk about our Regional Behavioral Health Response Plan, and a lot of the work that's been done on that, and some updates and some new things that really helps bring mental health providers to involved in our response systems.
Okay. Good afternoon, everyone. I'm Jan Dobbs, and I'm the Chief Operating Officer at Frontier Behavioral Health. And as you've heard from the presenters before me, Frontier Behavioral Health provides mental health services to individuals of all ages. In addition to that, we also provide services through our evaluation and treatment facility, in which we admit voluntary and involuntary individuals 18 and above. And then we have a stabilization unit where we can admit up to 16 people at any given time for a short period of stabilization. I was asked a few years ago if I would be interested in joining the Healthcare Coalition. And without knowing very much about it, one of the first things they asked me to do was to be involved in the creation of the Behavioral Health Disaster Response Plan. And not knowing what any of this meant, I agreed to do it. And the first thing I did was I got together a group of stakeholders, and Sharon in the back there was one of the stakeholders who was involved in this project with me. And the idea was, as a system of care within the region, how could we put together a plan that we could get out to all of our partners and have some level of agreement on how we would respond if a disaster did occur, and mental health or substance use services was needed for the individuals that were involved in any type of event. And so Sharon and I and the other members, we, of course, went to the internet and started to look at what do people have out there. And there wasn't a lot. Surprisingly, back then, behavioral health response in a disaster was not a priority, and probably did not become a priority until some of the disasters occurred, like Katrina. And then that started to get people's attention. And they started to think about, what do we do with people who have a mental illness or a substance use disorder? So there wasn't much out there, but whatever we found, know that we stole and created and tried to adapt it to our own community. And so this is the plan that we've come up with. How many of you have even seen it? Okay, great. Oh. Okay, then I'll tell you what it's all about. I'm not going to go through a lot of this in the beginning because I think that you probably understand the principles of the plan. If there were to be a disaster, who would you contact? How would you activate the mental health or the behavioral health system of care? And what resources are available within your community? Well, what we did was we looked at what kind of authority do we have to even have this plan, and you can see up there it talks about the local emergency management. And then what we decided was we really needed a single point of contact to activate this. And of course, we went to the BHO. Frontier Behavioral Health contracts with the BHO for the mental health services that we provide and for our inpatient units as well, and medication services that are provided. BHO contracts with practically every mental health provider in our community, as well as every substance use provider. So because we are under contract with them, if they call us and say, hey, we need you to do X, Y, and Z, we're going to be responsive to them. Every single community within the state of Washington has a BHO. So every county has a BHO that they are responsive to if they provide mental health or substance use services. So it was really logical to use them as a single point of contact. Emergency management has one phone number to call. And that one phone number, 24/7, will get them to the administrator at the BHO. Now, when the information is shared with the BHO about what the event is and what kind of resources are needed, what the BHO will do is they'll look at this response level. If it is a level 4 response, then they're probably going to call someone like Frontier. Remember, they have a lot of providers. We're one of them. They could call us and say, hey, there's an event going on. Can we take 5 of your staff to respond to this event? Then they could call Lutheran Community Services and say, hey, we want 3 from you. And they could call YFA Connections, a substance use disorder program, and say, can you give us 5 people as well? So depending on what the event is, that will determine what level of response they're going to be asking for. So at the lowest level, it'll be people who are at work, and they have all these providers, and they can select which providers they want to have involved and how many staff do they need to help with the event. If it was a level 3 disaster, then they're going to go beyond the people at work, and they may ask us, can you bring in some of your staff who are not currently on site? Because we operate facilities, we have staff that work 7 days a week, and they work different shifts. So during that event, they may not be at work, but they may be someone we could draw upon. If it's a level 2 disaster, then that expands it a little more, where it's not just the people or the agencies that the BHO contracts with, but then it may be private practitioners. They may reach out to Providence and say, hey, we've got this going on and we could use some assistance here. And then a level 1 disaster, that's like all hands on deck. Whomever you have available, it doesn't really matter if you're with the BHO or not, doesn't matter if you're in private practice, we need you. We've got an event, and the response that's needed is pretty vast. You can see that what we would like to do is have our staff trained in psychological first aid. The one thing that we know about disaster response in terms of mental health is that that is not the time to try to do therapy. That is not the time to try to gather a bunch of people and do a group. What you're looking at is what is going on with that individual, and you're actually trying to triage them, because it doesn't make sense to provide a service to them at that time. Our medical director, Dr. Tran, was just back at the APA conference, and one of the speakers that they had was an expert in PTSD. And what he was telling all of those psychiatrists there was that what they've shown, they've done studies because of 9/11, and what they're showing is that people who received services, mental health services, as a result of a disaster felt that they were worse because they were re-traumatized by the treatment, by the questions, and by the processing of that information. So that's really interesting, but you could probably see how that would happen. And so Dr. Tran is going to share that information for me, because that may have an impact on what this might look like in the long run. So there are, psychological first aid. We encourage our staff to sign up with the Medical Reserve Corps. We ask them to take a look at the basic training on incident command so that they would understand the structure and how they fit within the structure and who does what, so that they have an idea of what is going on. You can see that, if there's any opportunity for us to be involved in a tabletop exercise or an actual drill, we are always interested in participating, because still mental health and substance use providers are oftentimes forgotten. Everybody is involved in the tabletop exercise, the drill, but somehow mental health and substance does not come to the forefront. So it really is that constant reminder, what are you going to do with that person now? you know, what type of resource might they need, what kind of triaging needs to be done so that they know that there are resources out there should they need them. And then you can see on E the triage levels. In terms of the BHO, you know, they're going to be figuring out what type of staffing is needed to respond. So they will have their own set of information that they're using to triage who's going to respond, how many are going to respond, for what period of time, etc. And you can see the service delivery sites. The one thing about mental health and substance use providers is they're used to being mobile. So, you know, a lot of them are able to go out into the community and provide that service out in the community. It doesn't have to be an in-office type of thing. So that gives you a pretty quick overview of this. I think that the main things to remember is that there is a single point of contact. We try to make it as easy as possible. One number, one person. That individual then will get to their contracted providers to try to get the type of staff that's needed, the number of staff that are needed, and then dispatch those staff. Do you have any questions?